Our second anatomical site to investigate today is head and neck. Our physician presenter for this site is Dr. Michelle Williams. Dr. Williams is an associate professor, Department of Pathology, Division of Pathology, Lab Medicine at the University of Texas MD Anderson Cancer Center, Houston, Texas, and the co-author of the WHO Classification of Tumors, Pathology and Genetics of Head and Neck and Endocrine Tumors. She earned her MD from the University of Florida College of Medicine and served postgraduate training in head and neck pathology and surgical pathology at the University of Texas MD Anderson Cancer Center. Our CTR presenter is Carolyn Callaghan from the Puget Sound SEER Registry Cancer Surveillance System located at Fred Hutchinson Cancer Research Center in Seattle. Ms. Callaghan is responsible for initial content development on the SEER Educate website and trainer of central registry staff in the areas of case finding and coding.
Good afternoon. My name is Michelle Williams, and I'm a professor at the Department of Pathology at the University of Texas MD Anderson Cancer Center. And what I want to share today are two cases for which I practice every day, which is head and neck pathology. And we'll go through the different components and staging, as well as some of the other documents you may be needing to complete your registry positions. So our first case is a 58-year-old man with a 4-month history of a painful lesion at the right side of his lip. And it's noted to extend inside his mouth to his cheek. Now, on clinical examination, there's a firm mass present, so clinically it's very suspicious for cancer. The biopsy was performed, and that confirmed that it was invasive squamous cell carcinoma. Now, to begin with, we have a clinical history that says lip, but it's really unclear what the primary site is and which chapter we should use for AJCC staging. So in the 8th edition, we talk about the lip, and we need is what they sometimes call the dry vermilion, which is the sun-exposed external portion. Interesting, although this is our lip, everything that's exposed to the sun would be staged by the head and neck cutaneous chapter, which is chapter 15. You can see in the bottom image that this lip cancer is easily visible when the patient has their mouth closed, and therefore that would be a cutaneous example. However, we noticed in the clinical history they talk about it extending into the mouth. And so these are clinical pictures from this case where there's an internal erythematous lesion. You can see that the lip is having to be pulled up to see it. You can see that it's irregular and red. And here on the left, and that this is the angle, or right here at the commissure, that corner, and it extends then into the mouth, and this would be the inside of what would be buccal mucosa, or sometimes we call it, of course, the inside of the cheek would be the generic name. And so this is our tumor and the location. So in fact, what we're dealing with is mucosal lip, which then would use the oral cavity chapter. So this patient underwent surgery, and the pathology showed and confirmed it's an invasive squamous cell carcinoma. It was moderately differentiated, and the side was 3.4 by 2.1 with a depth of 1.2 centimeters. It did involve the mucosal lip, designated as the right commissure, so not specifically upper or lower, and it extended to the buccal mucosa. So this information is critical as we do the pathologic staging, and here it is for the primary tumor characteristics. So I'll refer to the chapters in the head and neck by name as well as the number, and I think sometimes that's helpful because they added quite a few different chapters for head and neck in the 8th edition. So here we can look at the T category for the oral chapter called oral cavity and lip. And again, when we refer to lip here, we're talking about mucosal lip. And the big change that occurred in the 8th edition is that the depth of invasion is also included as a risk factor, which could increase the T. So we've always used the primary tumor size. So a T1 is up to 2 centimeters. A T2 is up to 2 and or greater than 2 and up to 4, and then T3 were over 4. You can now see in red that if a tumor has a depth greater than 5, it gets upstaged to a T2, and if it's greater than 10 millimeters, it becomes a T3. So we can look at our case, and while by the initial gross size of 3.4 centimeters, it would have been a T2, in fact, the depth of invasion, the 12 millimeters, makes it a T3. In this case, it was a mucosal resection. We did not have any other additional structures, so there was no bone removed. It wasn't lower to the mandible or upper to the maxilla, and did not extend posteriorly. The masticator space, for example, is at the back of our jaw where we chew. So this would be the area. And so since we had an anterior tumor, none of the criteria in T4 were met. So here we have our T3 for this case. Now I want to talk just a minute about depth of invasion to make sure that as we look at reports and look at sizes, that we're all talking about the same determination, and that in fact we have to be very careful for oral cavity since it now is part of the PT determination. So depth of invasion, they've defined it as the basement membrane from the adjacent normal, here on the left, going down to the deepest part of the tumor. And so in this tumor, it's only 1 millimeter. That's the depth of invasion. But in this example, the tumor has a much greater thickness. That would be from the very top of the tumor down. And so it is very important as we gain numbers from the report to make sure that we're talking about the depth of invasion if we're needing to use the oral cavity lip chapter. So what can help us out, depending on who's formatting the reports, there has been a move for standardization of structured synoptic reporting to ensure all the necessary data elements are provided for patient care, which really aids, of course, what you need to do, which is gathering the information for the registries. So the College of American Pathologists, CAP, has protocols for for most of the cancers, and this is for the oral cavity in this case. You can see that things are listed that it was an excision, oral commissure on the right, as we discussed. It was only a unifocal tumor, and here we can see that the depth was 12 millimeters. What is important to know is sometimes we list 3 sizes for tumors. And so if it was just with 3 dimensions, we have to be careful not to assume that third dimension equals depth because it could equal the tumor thickness. So if we continue on, this patient at the time of surgery also had a right neck dissection. They removed levels 1A, 1B, 2, and 3. So since it's a right neck and it was a right-sided tumor, we're ipsilateral, and this would be called a selective neck dissection because they did only some levels. When we examined them under the microscope, we found 1 of 26 lymph nodes had metastatic squamous cell carcinoma. Now, the focus of tumor was small, only 5 millimeters, but it did show extranodal extension. This was viewed as what they consider microscopic 1 millimeter. And so we can see that even though it was a small tumor in the lymph nodes, how this will impact the patient's overall prognosis. The 8th edition of AJCC had a significant change. Instead of just viewing the number or the location of the positive lymph nodes and the size, they added this extranodal extension, which is something that can be done clinically by radiographic means, but that's going to be for gross, and I'll show you examples. And in this case, of course, we're talking about microscopic evaluation of whether or not the tumor in the lymph node breaches the node into the adjacent adipose tissue. You may hear the term sometimes extracapsular extension. This term is not preferred because it can be confused with a tumor capsule of the primary. And so you'll hear E&E or extranodal extension when we refer to this element. So in this diagram, it's a typical head and neck dissection where we can see all the levels laid out. So level 1 here is under the chin, 1B has submandibular and some lymph nodes, 2, A and B is our upper jugular, 3 is mid jugular, and then 4 is the lower jugular lymph node chains. Often for head and neck, they come into these upper levels first, and then as they go down towards 4, they typically are more advanced cancers. So this is what I see under the microscope. I have a lymph node, which are all the blue lymphocytes, part of our immune system, and it has collected a tumor cell that now has expanded to this tumor that is in fact breaching what should be a nice border to the lymph node, and this is spreading into the adipose tissue. Extranodal extension is present. Now, this determination has been added to the majority of the head and neck chapters, except the ones that are viral associated, so our HPV oropharynx, nasopharynx, which is associated with EBV, and then a few unusual tumor types, which is the mucosal melanoma, sarcoma, and thyroid, do not use the E&E as part of the end determination. So based on the current guidelines, we try and estimate where the capsule was, and we measure the extent, which is where the MI comes from for microscopic, or it can be determined to be major if it is over 2 millimeters. The extent, though, does not change the PN determination. So when we do the nodal evaluation now, for example, for oral cavity, as in this case, this diagram I found very helpful to use clinically because I can put all the parameters I need to know in one place, and then I can determine where this patient falls. So in this case, we know that it was right-sided, and it was a right neck, so it's ipsilateral, so up in the top. Excuse me. We're in the upper part here. This is ipsilateral. And then we can see that the size of the lymph node was small. It was only 5 millimeters. But in fact, we said that extranodal extension was present. So we have a single node that's small, but we jump over here and it becomes a PN2A because the extranodal extension was present. So we can see that if it had not been present, we would have had an N1, and that this factor is viewed as significant for prognosis purposes and overall determination. This is for the first time, and it's actually a quote from the AJC manual, that in head and neck, different clinical and pathologic end classifications are being used for regional lymph node metastasis. And so this is very important because one is that something microscopic will not be able to be viewed clinically. They won't be able to necessarily feel that there's extra nodal extension. If it is significant enough, what we call gross extranodal, then they may see blurry borders on what would be, in this case, a cystic neck node, as highlighted in the red circle. And if this finding is present, because it has to be more than just what I could see under the microscope, they become a CN3B by definition. But you can see that these other determinations otherwise do shift and are different than what was in the pathologic staging. And I'll leave those for your comparison, but just know that this is a shift. For those of you who have done staging for a long time, these are new parameters to evaluate. So if we put the case together, we had our 58-year-old man. He had a tumor that, although by size would have been a T2, by depth became a PT3. And because of that, lymph node metastasis with extranodal became an N2A. And that actually puts this patient in a poor prognostic stage of 4A. So with that information, I am going to pass off to Caroline so that she can provide the additional elements for this case. Thank you, Carolyn.
Hello, my name is Carolyn Callahan, and I will be discussing the coding portion of the head and neck cases. There's a lot to cover in a short amount of time, so I have provided a lot more detail on my slides than I normally would, and since we won't be able to discuss everything in detail, I have also provided a PDF document that discusses some of the issues regarding these cases. So let's jump right in. So this is the case text for you with an additional clarification from the physician. The chosen primary site for this case was C005 mucosa of lip NOS, but the primary site was reviewed with the physician due to ambiguity regarding the primary site. There was a painful lesion that was centered in or arose from the mucosal lip, but it was not clearly stated to be in the upper lip or the lower lip. The physician clarified that this was at the commissure and not the upper or lower lip. However, this was confirmed to be a mucosal lip primary and not a skin of the lip primary. The ambiguity regarding the primary site for this case is discussed in that PDF document in more detail. So for the solid tumor rules, we have Rule M2. There was only a single tumor arising from the mucosal lip, so it's a single primary. And for the histology, we have Rule H1, and the histology is coded as 8070 or squamous cell carcinoma NOS. The only histology documented from the biopsy and the resection was just invasive squamous cell carcinoma. For the grade clinical, we have 9. There was a documented diagnostic biopsy, but no clinical grade was given, so no clinical grade can be coded. Remember that grade must be coded based on the time frame, and only the grade from the clinical time frame can be coded in this data item. The subsequent pathological grade cannot be coded in the grade clinical data item per the grade coding instructions. For grade pathological, the correct code is 2 or moderately differentiated. The surgical pathology diagnosis was invasive squamous cell carcinoma, moderately differentiated, and the applicable grades for mucosal lip primaries include G1 through G3, or well, moderately, and poorly differentiated. Grade post-therapy is blank because this patient did not have neoadjuvant therapy. The patient proceeded directly to surgery. So EOD primary tumor for lip primaries is based on both the extent of the tumor invasion as well as the depth of invasion, or DOI. The EOD primary tumor tables don't seem to make much sense until you look at the notes that outline how to determine which group the tumor belongs to. As note 3 for this site's EOD primary tumor table indicates, once the correct group is determined, the codes are then chosen based on the depth of invasion. So locate your group from note 2 first if the tumor is not obviously extensive or involving sites listed in the greater EOD primary tumor categories. Those would be codes 550 or greater. For this case, we had a tumor that was 1.2 centimeters deep, but that involved the mucosal lip, the right commissure, and the buccal mucosa. So find the group 1 or 2 that applies to the tumor from the EOD primary tumor notes, and then use the depth of invasion from the EOD primary tumor codes. Our tumor would be group 2 based on that buccal mucosa and commissure involvement. So the selected EOD primary tumor code is 500 for this case because the group was 2, the tumor involved the buccal mucosa and the commissure, and the depth of invasion was greater than 10 millimeters. It was 1.2 centimeters or 12 millimeters deep. For the EOD regional nodes, we have surgical pathology that included a right neck lymph node dissection, and the findings included metastatic squamous cell carcinoma present in 1 of 26 lymph nodes. The metastatic focus was 0.5 centimeter in greatest dimension and showed extranodal extension that was microscopic, measuring 1 millimeter. So EOD regional nodes is coded based on whether the nodal involvement was clinical or pathological, the number of nodes involved, the size of the lymph node metastasis, and the presence of extranodal extension. The selected EOD regional nodes code for this case is 150 because this is a pathological only category and this patient's lymph node involvement is considered pathological based on that right neck lymph node dissection. Only 1 lymph node was involved. The lymph node metastasis was less than 3 centimeters in size. It was only 0.5 centimeter, but there was pathologically proven extranodal extension. For EOD METs, we have clinical and surgical findings to consider. The physical exam noted a painful lip lesion, but there was no mention No clinical mention of distant metastatic disease. The surgical path proved regional tumor extension and regional lymph node involvement. So the selected EOD METS code is 00. There was no mention of distant metastasis. The patient underwent an adequate workup followed by surgery that proved a regional tumor only. A negative physical exam alone is adequate to code EOD METS to 00. Since EOD METS was coded to 00, the individual METS fields must also be coded to 0 for none. So summary stage 2018 takes all three components of EOD into account. The EOD primary tumor was regional by direct involvement or direct extension, since involvement of both the buccal mucosa and commissure are listed under summary stage 2018 code 2. EOD regional node involvement was present. There was one regional lymph node METS proven by that right neck lymph node dissection. And regional lymph nodes are listed under summary stage 2018 code 3. There was no evidence of METS. So combining the three components of EOD, code 4 is the appropriate summary stage 2018 category. There was involvement both by direct extension and regional nodes. Our first SSDI is extranodal extension head and neck clinical, which records the clinical presence of ENE in clinically detected involved regional nodes. But there was no clinical evidence of lymphadenopathy on physical exam, and a physical exam alone is adequate to assess the presence or absence of clinical lymph node involvement. So the selected SSDI code is 7, no lymph node involvement during the diagnostic workup. This SSDI is discussed in the PDF document in more detail. The next SSDI is extranodal extension head and neck pathological, which records the pathological presence of ENE in involved regional lymph nodes. The lymph node dissection proved one involved regional node with microscopic ENE measuring 1 millimeter. A lymph node dissection is a pathological assessment, so the selected SSDI is code 1.0. The actual size of the ENE in the range 0.1 to 9.9 millimeters, recorded to the nearest tenth of a millimeter. 1 millimeter recorded to the nearest tenth is coded as exactly 1.0 for this SSDI. And our last SSDI is lymph node size. This records the diameter of the largest involved regional node, with pathological measurement taking precedence over the clinical measurement. The documented lymph node dissection proved one regional lymph node METS measuring 0.5 centimeters or 5 millimeters. No other information regarding the size is given, so the size of the METS is coded. Our selected SSDI code is 5.0, the actual size of the node to the nearest tenth of a millimeter. Half a centimeter is 5 millimeters, and 5 millimeters to the nearest tenth is coded as exactly 5.0 in this SSDI. The only size is the METS size in this case, and there are many posts in the CANSER forum regarding the coding of lymph node size versus METS size, but a recent post confirms the size of the METS may be coded. This SSDI is discussed in the PDF document in more detail, and it also includes that CANSER forum post.
So let's move to case 2. So we have a 41-year-old male who presents with a left neck mass. Clinically, it was a large 5-centimeter lymph node in level 2, so high in the neck. And when clinically they evaluate, they see if it moves. Again, if it was fixed, that would be a sign of extranodal extension, as we talked about in the first case. But here it's very mobile. And by imaging, it has smooth borders, and I'll show you that picture. So there's no clinical evidence that it has extranodal extension. The first thing you need to do when you have a mass is determine, is it in fact cancer or something else? And so a fine needle aspiration is a type of biopsy that was performed, and it was positive for metastatic squamous cell carcinoma. So as this patient presents, perhaps in the community, it begins as a patient of an unknown primary. He has cancer in the neck, but we're unsure where it comes from. I point this out because this is a new chapter in AJCC, Chapter 6, and we'll start with it until we know where the primary is for this case. So if in fact a patient presents, this is very common, over 30% of our head and neck patients present initially with their neck mass, and then imaging biopsies are performed to determine where the tumor is coming from. Now, if a tumor cannot be located in another site, then using Chapter 6, they provide guidelines which say we actually need to do a little bit more pathology to determine how we should stage this. So the recommendation now is that a lot of patients who have what is called HPV-associated squamous carcinoma, and that's specific to the oral pharynx, present, as we discussed, with a cystic neck mass. And so evaluation for P16 is recommended and really needed for your proper staging. If that's negative, or depending on the morphology, EBER, which is one type of way we can test for EBV, can also be performed, and that would help exclude that the origin of that unknown primary is nasopharynx. Now, patients with oral pharynx or nasopharynx, which we'll talk more about their sites, may be without much in the way of symptoms. And so that is why they're unknown, because clinically the patient's not complaining, and yet clearly it has already spread. Quick note, this chapter for unknown primaries is specific to squamous carcinomas. It should not be used for other unknown primaries that we sometimes see in this area, such as adenocarcinomas. So this patient, our patient, did have that additional testing. That tumor cells were positive for P16, which means that they're diffusely positive, and that the high-risk human papillomavirus test was also performed and was positive. Now, we don't always get both tests. In the neck, if it's in level 2 and 3, that's a good correlation, but particularly in other sites, making sure that we don't have non-specific findings would be important for me clinically as I'm evaluating a patient. So in this scenario, if he is P16 positive and remained an unknown primary, we would then know we need to use Chapter 10, the HPV-mediated P16 positive oropharyngeal cancer. Now, this case we know goes on to find it in the base of tongue, but this can teach you how to work through it. And there probably are perhaps 10% of patients that will remain in this stage where, despite good imaging, good clinical exam, and follow-up, we do not find that primary site. So in this case, the nodal staging actually changes. So HPV-mediated P16 positive oropharyngeal cancers are different. And I'll talk a little bit why they're clinically different and pathologically different. But what I want to say is that the extranodal extension, which we actually still apply to our cases, does not change the PN. And so that's what this is implying. We've simplified ours just to the size of the lymph node for the clinical determination, as well as then whether it's IPSI or contra. And so it's a very simplified chart here, and we see that even if there are multiple nodes, clinically it would be an N1. When they're extra large, over 6 centimeters, which they can do, that's then when they can go to N3. And if they're onto the contralateral side, which can happen particularly when we're talking about oral pharynx, base of tongue, and so they can be on both sides of the neck, and those end up as a clinical N2. And so very common in oropharyngeal HPV positive, these nodes will be cystic, which is why the center of this node is actually dark. So in our patient, the CT scan was performed. We see this very smooth border to this asymmetric area. So that's the good news, is we can compare from our rights to our lefts in radiology to know that that's the abnormal finding. It is high in the neck, and so it's a level 2, and it has smooth borders. So clinically, there is no extranodal extension. So radiographically and clinically, it's a CN1. So let's just get back real quick for what is the human papillomavirus? Why are we talking about it more? And why did it get its own chapter in the new AJCC staging? So what is it? It's a virus that there are many, many, many different types, but there are a number of them that we consider high risk, which means those types are associated with cancers. They're the same virus we've talked about in the GYN arena and cervical cancers for decades. They can also cause things like anal cancer. But in the head and neck, they cause oropharyngeal cancers, so tonsil, base of tongue. The high-risk types we typically see are type 16, over 90%, and then some 18 and a little bit of those others that are shown. And so that is what we're talking about. It's a virus that's spread, and hopefully the vaccine truly will reduce the risk of subsequent cancers. So that's just, yes, HPV vaccinations are available, and they are recommended through the medical agencies. So where do we find this HPV in the head and neck? Specifically, and really this is a highlight, an asterisk, the oral pharynx. So our guidelines talk about testing for HPV. We're testing only oral pharynx and those unknown primaries. What is the significance? They're biologically different with improved prognosis. And so obviously a patient wants to know, I have cancer, but how does that compare and what does that mean? You noticed our patient was fairly young, 41. HPV does tend to be in younger population compared to our traditional head and neck cancer patients, which tended to be older and associated with smoking. It's still very prevalent, but this in fact is affecting a different population. And so how do we test for it? You'll see the comment about HPV-specific testing, which there are a number of different testing possibilities. That can be expensive and not widely available. And so we found that P16, which is an immunohistochemical study, is fairly easy to evaluate. It has strong overexpression, and in fact, it works very well as a surrogate. Again, not perfect, but if you test the oral pharynx, particularly, and or these unknown primaries in the right location, it will associate with what we're talking about. So these were the studies that were done. And it really showed that for patients who are HPV positive, that at 3 years, their survival was high. You can see it was about 82%. And yet at 3 years, if you did not have the virus, it was down below 60%. So patients want to know, they are looking to see if they can change some of the treatment, mainly to reduce side effects in this younger population. And this is why we have our new staging. So let's get to case 2. So in this patient who presented with the neck mass, they did find the primary in the base of tongue. So at our institution, we have a surgeon who does a lot of these robotically, and he actually removed the primary tumor. It was described as polypoid, and it was 2.5 by 2 by 1.4 centimeters. By pathology, it was an invasive squamous cell carcinoma of the base of tongue. But it's very important to know that we talk about the base of tongue as a general regional site, and that if we read the operative note, in the left base of tongue, there was an exophytic tumor centered over the left lingual tonsillar tissue. It did not involve the vallecula. The tumor was noted to be confined to the base of tongue without involvement of the lateral pharynx, and the tumor did not cross midline. There were no other mucosal abnormalities noted on endoscopy. So when we talk about base of tongue, in fact, we're talking about an area that is covered and includes the lingual tonsil, and that in fact is where the HPV tumors clinically arise. So typically if it says base of tongue in an HPV positive tumor, look to see if you can find additional information because likely it's arising in the lingual tonsillar tissue. This is what it looks like. There's a little bit of normal tonsil over here on the right side, and it's just dark with lymphoid tissue because our tonsils are part of our immune system. They look a lot like a lymph node. And in fact, then the mucosa comes down within the lymphoid tissue, and the tumors often actually develop in what are the crypts. So they're not always on the surface. And so we can see that this tumor here fills this part of essentially replacing the lingual tonsils. So I've been talking about oral pharynx, and we already had something of the lip and oral cavity, but where's the distinction? I know in training our residents and fellows in pathology, this is an area that sometimes they pick the wrong staging, because if we're in the wrong chapter, then we essentially get the wrong answer. So it is important to know that the oral pharynx includes the soft palate, which includes our uvula, the little middle part on the top of our mouth in the back, our tonsils on both sides, which include the anterior and posterior pillars, the base of tongue, which of course we're talking about the lingual tonsils, so it's the posterior 1/3 of our tongue. And these are all what are considered oral pharynx, part of Waldauer's ring, which is our immune system in that area, and biologically where HPV can occur. We need to distinguish this, and that's very different for staging prognosis from oral cavity. So you have the gingiva. For the oral cavity, we have the sites of gingiva around the teeth, alveolar ridge, our hard palate, the maxilla, retromolar trigone, oral tongue, so the anterior 2/3. Often the tumors are on the lateral surface, floor of mouth, and of course we've discussed mucosal lip. So we can see in this diagram the gray in the middle. That is the oral pharynx as we go back, as we begin to swallow, and that all the other components would be part of that oral cavity. So if we talk about pharynx just briefly, just to understand the chapters in AJCC and how we reach the correct one to use for staging, the nasopharynx is often associated with a viral Epstein-Barr virus, EBV, that's chapter 9, and it is higher than the oral pharynx, but part of that upper respiratory tract, beginning behind the nose and going down along what's called fossa Vossmuller, which is where your eustachian tubes open next to your adenoids. So that's the lymphoid tissue there. We've talked about the oral pharynx and the sites it includes, and so that's there in blue. And then, of course, if you go lower around the outside tissues where you swallow, the larynx is where we breathe, and then the hypopharynx is where the tissue goes around the larynx before it begins to get to the esophagus. That is a separate staging, and they also include the oral pharynx that are essentially P16 or HPV negative in that chapter 2. These all three sites have different biologies, different prognosis, and therefore now all have different staging chapters. So if we just compare briefly, what is the HPV mediated, how are the PTs determined versus the HPV negative oral pharynx and hypopharynx chapter, we can see that in many ways they're the same. So our PT is determined by the size of the tumor. So up to 2 is a T1, up to 4, greater than 2 is T2, and over 4 becomes a T3. And they also describe that that is a tumor that may extend to, for example, the lingual surface of the epiglottis. So our base of tongue and adenoids are posterior, and so that's the adjacent subsite. We can see that for HPV positive, they do not divide out T4, which is based on the extent divided into a T4A and T4B, moderately versus very advanced, for those that are unrelated to HPV. So our patient at a 2.5 centimeter is a PT2. So this patient also had neck dissections. They were of the left neck only. So again, a selective neck dissection, 2, 3, and 4, because that's where this tumor may spread. And the patient had metastatic involving a total of 2 of 35 lymph nodes, and there was no extranodal extension. That was missing from your dictation. It said with, and then it left that out. So for your final registry information, you can include that was negative. We know the largest was 5 centimeters, but on pathologic examination, there was one more. So compared to that first case, which I showed you in infiltrating fat, and we got to measure it, even at low power here, we can see that it has a nice smooth border. And so this is in fact no ENE or extranodal extension. And again, it does not change our PN, but is a factor that is recorded for each chapter. So what does it look like now for an HPV positive oral pharynx PN determination? It's actually quite simplified. So the size of the lymph node doesn't matter. whether it's ipsilateral or contralateral for the PN, again, it mattered for the clinical, but not for the pathologic, doesn't matter. And it doesn't matter whether or not I find extranodal extension. So at this time, it's been simplified to essentially PN1 if there are 4 or fewer lymph nodes, and PN2 if there are more than 4 lymph nodes with metastatic tumor. This is important going forward. Again, studies have suggested that these patients, even when they present with large nodes, do better. But again, more information will be gathered to see if these are the right breakpoints for future additions. Now, when we do the P, N, and M, obviously they're all combined for a final prognostic stage. And I think it's important just to, again, highlight why this new chapter is there and how it really impacts using the correct chapter and where this patient falls. So when they're HPV mediated, which is here on the left, we can see that even when you have neck nodes, whether it's more than 4, whether it's bilateral, you in fact end up here in only a stage 1, 2, or 3. And that's very, very different than, in fact, when you don't have the virus. It's more traditionally then again tobacco related. And here, even a single lymph node makes you a stage 3. And very quickly you can see as you have extranodal extension or contralateral lymph nodes, this stage and prognosis becomes quite poor. So again, having that information of the status for any oral pharyngeal primary is critical for proper staging and treatment. So this patient ended up as a PTN PT2N1, and that is actually a prognostic stage 1. So before I hand it off to Carolyn, I just want to do a real quick comparison for you between these cases. So what we heard is that, of course, knowing where the tumor starts may require clinical information, operative notes, and pathology. And that pathology sometimes is simplified to what was resected and removed, but gathering all the information can really lead us to understand the extent of tumor. So in this case, in both of our sites, we had a squamous cell carcinoma. It is the most common. Over 80% of what we see in the head and neck will be this diagnosis. But again, the prognosis is site dependent. So on our lip, mucosal lip and buccal, our oral cavity chapter, depth was very important. That upstaged it, as well as then, even though it was a small lymph node metastasis, only 5 millimeters, the presence of the node itself and then the extranodal extension really changed the prognosis in this patient to stage 4A. The HPV-associated oropharyngeal cancer, on the other hand, still by size, is a T2. Again, the depth, in fact, does not matter. It doesn't play a part. And although the node was 5 centimeters, and in fact there were multiple nodes, this patient actually is put in a good prognosis category of stage 1. And so you can see where these details all come together, and that part of what you do is critical so that as we gather more information, we can continue to delineate these chapters. And so thanks to all the data that's been collected in previous years, because all of the data goes together to make these changes for the new additions. So the new edition, which it still feels new, even though it's now been around a couple years, really reflects the evolution of staging. We included things that were new that increased patients' risk and essentially said that they would have a poor prognosis, as well as things that lowered risk. And so we talked about the higher risk being this extranodal extension for both recurrence and mortality, as well as the depth of invasion. And so those things were added to our chapters as discussed. Lower risk biology, these viral related. Again, these are on the rise. You likely will see many of them. Many may not be resected, but you'll be staging them based on the biology and original biopsies, which could be either identified or treated as an unknown primary in the subset that were not seen. And so with that information, I turn it over back to Carolyn to discuss the additional parameters for case 2 for completeness. Thank you.
Okay, let's jump back into case 2. Again, just a reminder of the case text here. And this is additional clarification from the physician regarding this case. So per the physician, the tumor was localized without extension into the deep musculature or extension to adjacent sites or structures. The operative findings were provided and proved the tumor was arising from the lingual tonsil. The primary site for this case was confirmed to be the lingual tonsil, which is often described as being base of tongue for these HPV-related tumors per the physician. There was no involvement outside of the lingual tonsil. So primary site was C024 or lingual tonsil, per clarification with the physician. The operative findings described this as an exophytic tumor centered over the left lingual tonsillar tissue. And even though other case text calls this a, quote, base of tongue tumor, both the physician and the operative findings confirm a lingual tonsil tumor. So issues regarding primary site coding are discussed in more detail in that PDF document. For the solid tumor rules, we have Rule M2 again. There was only a single tumor in the lingual tonsil, so a single primary. And for histology, we have Rule H1 and Code 8070, squamous cell carcinoma NOS, as this is the only histology documented from the primary tumor. The resection proved squamous cell carcinoma NOS. And tissue or pathology from the primary tumor has the highest priority for coding histology. So the lymph node FNA in this case cannot be used to code the histology. Again, issues regarding histology coding are discussed in more detail in that PDF. Grade clinical should be 9. There was no biopsy of the primary tumor during the clinical timeframe. Only an FNA of a lymph node metastasis was performed, and grade may only be coded from the primary tumor. So since no clinical grade was given, no clinical grade can be coded. Grade pathological is also 9. The documented surgical pathology diagnosis was just invasive squamous cell carcinoma. There was no grade given. So even though the case meets pathological time frame requirements, no grade was documented, and so no grade can be coded. Grade post-therapy should be blank because, again, this patient did not have neoadjuvant therapy, but proceeded directly to surgery. So EOD primary tumor was clarified with the physician, and this tumor was centered in the left lingual tonsillar tissue per the operative findings and was localized without extension into the deep musculature of the tongue, adjacent structures including the vallecula and lateral pharynx, and there was no extension across the midline. There was no clinical or pathological evidence of tumor outside the lingual tonsil, including into other tongue subsites. Again, the issues regarding EOD primary tumor are discussed in that PDF document. So here are some of the selected oropharynx HPV-mediated P16 positive EOD primary tumor codes, and we have a localized tumor in the lingual tonsil, which is included under the tongue base codes. So the selected primary EOD primary tumor code is 100, confined to site of origin or localized NOS. There was no clinical or pathological evidence of tumor outside the lingual tonsil per clarification from the physician. For EOD regional nodes, clinically, we had a single large left-sided node that was positive for metastatic squamous cell carcinoma on FNA, and then the surgical pathology included a left neck lymph node dissection that proved metastatic squamous cell carcinoma in 2 of 35 lymph nodes. The metastatic focus was 5 centimeters in greatest dimension and was without extranodal extension. So the EOD regional nodes is coded based on the laterality of the nodal involvement and whether the involvement was only clinical or pathological. In this case, there was pathological evidence of involvement, so an EOD regional nodes code must be a pathological evaluation code. So the selected EOD regional nodes code is 500. There was pathological evidence from the left neck lymph node dissection, and it proved multiple involved lymph nodes. For EOD METs, we have clinical and surgical findings again. There was adequate workup, including a physical exam that noted a lingual tonsil tumor, and clinical evidence of regional lymph node involvement. The surgical path proved only regional lymph node involvement. So our selected EOD METs code is 00. There was no mention of distant metastasis. There was an adequate workup followed by surgery. And again, a negative physical exam alone is adequate to code EOD METs to 00. Since EOD METs was coded to 00, the individual METs fields must also be coded to 0 or none for this case. We're back to summary stage 2018, and we have to again take all three components of the EOD into account. The EOD primary tumor was localized, and localized NOS is listed under summary stage 2018, code 1. The EOD regional lymph node involvement was present. There were 2 regional lymph nodes with METs proven by the left neck lymph node dissection, and the regional lymph nodes are listed under summary stage 2018, code 3. There was no evidence of METs. So combining the 3 components of EOD, code 3 is the appropriate summary stage 2018 category because it is the greatest code applicable. We only had a localized primary tumor, but involvement of regional nodes. There are some issues regarding summary stage 2018 coding that are discussed in the PDF document in more detail for this case. Our first SSDI is schema discriminator 2, which is used to discriminate between oropharyngeal tumors that are P16 positive, P16 negative, and P16 unknown. The left neck metastasis FNA was positive for P16 and can be used to code this schema discriminator. This should be used to apply the appropriate coding scheme even though this was not performed on the primary tumor. There is clarification regarding P16 testing of lymph node METs in the C-Answer forum, and the issues regarding schema discriminator 2 and that C-Answer forum post are discussed in the PDF document in more detail. So in this case, we had a tumor that's P16 positive. This is used as a surrogate marker for HPV-mediated tumor and is coded as 2 for P16 positive in this SSDI. Our next SSDI is extranodal extension head and neck clinical, which records the clinical presence of ENE in clinically detected involved nodes. So clinically, a 5 centimeter left level 2 lymph node neck mass was identified. It was mobile and had smooth borders by imaging. The physician specifically noted that clinically no extranodal extension was present. So the selected SSDI code is 0, regional lymph node involved, ENE not present, not identified during diagnostic workup. Per the SSDI manual, code 0 should be used when nodes are involved, but the physical exam does not indicate signs of extranodal extension. A physical exam or a physician's statement of ENE are both adequate to code this SSDI. Our next SSDI is extranodal extension head and neck pathological, and again, this records the presence of ENE in pathologically involved regional nodes. The lymph node dissection proved 2 involved nodes. The largest metastatic focus was 5 centimeters and was without ENE. So the selected SSDI code is 00 for this case, lymph nodes positive for cancer, but ENE not identified or negative. The lymph node dissection did prove involved nodes, but there was no ENE. And our last SSDI is lymph node size. This records the diameter of the largest involved regional node with pathological measurement taking precedence over clinical measurement. the documented lymph node dissection proved 2 regional lymph nodes with METs, the largest measuring 5 centimeters or 50 millimeters. There was no other information regarding the size, so the size of the METs should be coded. Our selected SSDI code is 50.0, the actual size of the node to the nearest tenth of a millimeter. 5 centimeters is 50 millimeters, and 50 millimeters to the nearest tenth is coded as exactly 50.0 for this SSDI. Again, the only size is the MET size for this case, and we do have that recent CAnswer forum post indicating that it is acceptable to code the size of the METs. And this is again documented in that PDF document in more detail. So that's all I have. Thank you very much for your time.
Welcome to the live Q&A session for the head and neck cancer. So we have our presenters with us. So we have Dr. Michelle Williams as well as Carolyn Callaghan. So welcome, ladies. Thank you so much for taking time out of your busy schedule to be here today. So we'll go ahead and get started in answering the questions live. So Dr. Williams, we'll start with you.
So we've had a lot of questions regarding HPV, and so I'm just going to give a really quick kind of round out our discussion here. So the etiology of HPV, human papillomavirus, is the same that we see in the GYN tract. So it's the same virus that is contributing to this cancer. And we sometimes think that the virus probably leads to activation a little more simply than some of our smoking related cancers. And that's why they probably are doing better with our current treatments. So that was one of the questions for etiology. The vaccines, yes, if we can get enough of the people vaccinated, we should minimize the spread of the virus and in the end actually reduce the risk of cancer to the head and neck. So I encourage men, parents to have their kids vaccinated. That's boys and girls, the way our current vaccines are set up. And hopefully in a couple decades, unfortunately, it will take before we actually reduce this risk of cancer. For clinical purposes, P16 is an immunostain, and it is an easy test that's relatively available in places, and it's fairly easy to read. So if people know that it needs to just be pretty diffuse, like almost 100% of everything staining, then we can get the right answer. And so that's why in the pathology world of guidelines, that is the preferred method of testing. And that's why the chapters in AJCC were set up with P16 as the emphasis. We are actually told not to HPV specific test, which is usually what we call in situ hybridization. It's still off a slide, unless in fact, it's perhaps in the neck and we don't see that primary, or we're not sure if the primary is in the oral pharynx. If they are discordant, if the HPV test is a reliable test, which RNA actually is the best part for HPV, then clinically they will view that patient as negative. It is rare, it's probably less than 5% of cases, but the HPV testing DNA is not as reliable and could cause discord. Do you want to talk a little bit more about HPV coding, Carolyn?
Sure. So I think what's really important to recognize for the registrar side of it, especially with regard to histology, is that we can't use P16 positivity to code that HPV mediated specific squamous cell carcinoma histology code 8085. The solid tumor rules manual has pointed out that it must be based on viral DNA or RNA testing. So unless you have that positive HPV viral or viral DNA or RNA testing, you can't use that HPV positive squamous cell carcinoma code. We would end up having to code those based on like just squamous cell carcinoma if that's all you have. And that's really difficult because we see these being called P16 positive HPV mediated squamous cell carcinomas in the pathology reports. So I think the tendency is to want to code 8085. But again, currently the solid tumor rules do not let us do that. And we do have to follow SEER's guidelines for coding histology. Maybe that will be updated in the future, but right now we cannot code that.
So HPV testing is only available at large institutions or referral centers. And again, unless we're doing the RNA type specifically, it may not be as sensitive or correlative. And so, and it's at more cost. And so that's the reason the guidelines from pathology and testing really, you may have even seen a shift where you're seeing now more P16 only cases. And that's currently our guidance.
I see. Any other questions we would like to answer live and highlight?
We had the question on clinical staging, and certainly clinical, the T determination would be the same as the pathologic, but of course it's based on your clinical exam and the imaging studies. And so it is possible that a tumor is perhaps thought to be a little smaller clinically, and pathologically we find it bigger based on breakpoints. Occasionally it will be the other way, even though most of the time we will agree. And so again, we're using the information we have at each component to provide the appropriate AJCC component.
Okay, and just if I can highlight just for a minute for all of the conference attendees, the PDF file that Carolyn referenced, that is located in the files section, and you may have to refresh your screen. So it is posted there. Okay, thank you. We can continue with the live questions.
Someone asked, how do you do oral cancer staging without depth of invasion? You need to get the depth of invasion, and that should be in all the pathology reports. If we have 3 sizes, even though they may not say which one is the depth, again, we try not to make sure that that third size, we would like that third size to be clarified as the depth, not necessarily if a tumor thickness. But at a default, that would be the number that I would use if they did not specifically state it. I don't know if you have any other guidance on that, Carolyn.
I'm not sure exactly. I would have to look, but yeah, I mean, generally speaking, you should know which is the depth, and there might be some answers in the cancer forum about that, but I would have to look. So I don't want to comment and misguide people.
No, that's fine. And again, I didn't mean to put you on the spot. It was just certainly from a clinical aspect and how we either write reports or provide information. If the size was given as 3 dimensions, typically the smallest, the third dimension, would be viewed as the depth if it is not specifically stated for the purposes of staging.
Okay, are there any other questions we would like to answer live?
There are so many coming in.
They said examples of clinical E&E. So fixed nodes, matted nodes, nerves that are out. So they may already say that the patient has a certain palsy or it's involving certain nerves. All of those would be signs that it's grossly invading into the adjacent tissue and affecting, therefore, the adjacent structure. So any of those terminologies clinically equal matted, besides if a radiologist uses the term extranodal extension by imaging findings.
There was a question about primary site. The choice of coding the lingual tonsil C024 over the base of tongue, which is C019. So this was a tricky issue that I actually had to reach out to Dr. Williams about to clarify the primary site. I'm not sure if you did discuss this about the difference between the lingual tonsil and the base of tongue, but the clarification that we discussed was just that the primary tumor is in the lingual tonsil, that these tumors do arise in the lingual tonsil, if I'm saying that correct. These HPV-related tumors arise in the lymphatic tissue, and the lymphatic tissue in the base of the tongue is the lingual tonsil. So it is somewhat hair-splitting because they anatomically are basically in the same spot. So how do you decide between? I ended up going with C024 for Dr. Williams' clarification. This actually was brought up to the standard setters at SEER after I had this discussion in preparing this presentation. So hopefully we'll get some better clarification about using 019 versus 024. Did you have anything you'd like to add, Dr. Williams?
No, I mean, I think it's a very valid discussion. The operation is occurring at the base of tongue, which we know is where the lingual tonsil essentially is intimately integrated. So, so clinically, we know that the HPV, as you mentioned, occur in the tonsils, which are the lymphoid tissue, and the lingual tonsils, which is essentially at the base of tongue. And so, again, the coding versus the terminology we typically use for surgery is where, again, your coding is very specific, but you would need to make sure through all the documentation if you're able to code it that direction.
Okay. And I see a question here, Dr. Williams, regarding the age limit for HPV testing, and has that changed based on the current guidelines?
They did. Testing, or I should say HPV vaccinations, I believe begin at the age of 11, and that's boys and girls. But they did use a makeup period for into the 20s. So I can't necessarily give you the upper limit. Originally, it does not help to treat anybody who's been exposed. And again, that's one of the things that we want to be careful of. It's to help prevent infection. And that essentially, I would seek out information from your general care provider. And again, the vaccines are good for boys and girls, and some of the vaccines prevent genital warts as well as what we're talking about, HPV, which is within the same family.
Thank you. Okay. So I guess we can go to some final thoughts that you would like to share with us, and anything you would like to provide, any additional information.
I think that both of these cases highlight where we continue to change. Most of these, of course, are for prognosis. So we're trying to recognize patients that will do better, and therefore the overall stage and prognosis is reflected in AJCC. We still clearly have challenges. Our recommendations for how we're testing versus how you want to be very specific in coding certainly are not exactly aligning. And so hopefully on a national level, those are things that can continue to be worked on. But I think that really head and neck is a wonderful field, and just take your time going through to gather the information you need to do the full AJCC and the additional coding for that you do as registrars. And so thank you for all your effort.
Thank you very much. Anything from you, Carolyn?
I would just like to say that, as a registrar, you always cringe a little bit when you get a head and neck case, because they are among the more difficult cases to work on from the coding side of things. Everything is so small and it's all and trying to figure out, is this localized? Is this regional? What's the histology? It's very difficult. And I think that no one really wants to take these on, but it is really good to take your time, like Dr. Williams said, and try to find all the missing pieces. And then if there are questions and you are at a hospital or facility where you can contact the physician or the pathologist, that's very helpful, because I wouldn't have been able to do this presentation if I hadn't been able to talk to Dr. Williams about these two cases.
Thank you very much. And thank you both for being here live with us. We greatly appreciate you for being here. And to the conference attendees, if you have any additional questions for Carolyn or Dr. Williams, their email addresses are located in the conference brochure. Thank you. We are headed to a break, and then we'll see you again in the next case study, which will be on GYN. Thank you very much.
Thank you.